Hey, good afternoon. Welcome back to the 19th Indoanesthesia. So we come to the last two sessions and we're going to discuss about obstetric anesthesia. I think if you have followed Indoanesthesia for a while, you know that it has become a tradition that we start with obstetric anesthesia and usually we close with another obstetric anesthesia sessions. And for this session, we are very lucky because we have three prominent speakers in this field. The first one is we have Professor Victoria Ali. Hello from Australia. I believe it's good afternoon to Victoria. And then we have Professor Ban Lang from Singapore. And last but not least, we have Professor Frederic Mercier from France. I believe it's still good morning in France.
Yes,
And for the moderator for this, we have a very special moderator. We have Professor Anne-Sophie Bouters from France. Please, Anne-Sophie. I think you're still muted.
It's okay?
Yes, now.
Perfect. I want to thank Cicelo for and his excellent team to give us once the opportunity to share our experience and new knowledge. And thank you also for the rocky music breaks with the excellent singers and musicians, especially this morning. And I will ask to all participants to ask their questions on the Q&A chat, and I will summarize them at the end of the presentation. And now I have the pleasure to introduce Prof Victoria Ali from Australia, and she's a great specialist and researcher on obese parturients, and she will make a talk on the evidence base for care for obese parturients. Victoria, please. Have you? So your screen is shared?
I think your mic is still muted, Victoria.
Can you hear me now?
Yes.
Thank you so much for the introduction, and I find this is a very hard act to follow after that great music. So I'll do my very best to give a talk that was just as entertaining as the music. And thank you very much for inviting me to speak on this topic, which I think provides us with challenges every day, week and month that we care for pregnant women. So we know that rates of obesity are high in developed countries, and data from Indonesia in 2015 showed that 23% of adults are obese, and the rates are higher in Australia with 31% and higher again in the USA. So obesity and its associated comorbidities influence the types of surgery that we see and also how we provide anesthesia and analgesia. So I would suggest that as a specialty, anaesthetists try very hard to be evidence-based in our practice. In obstetric anesthesia, I think there's lots of different aspects that are different to non-obstetric anesthesia, and some things become particularly more important. As a rule, I think that we try to do our best for the support person who may be accompanying a woman, for the baby, for the post-operative nurses who may be looking after them, and for the midwives who are looking after them as well. And I think we try really hard to follow the best evidence to do this. But I think we would also probably acknowledge that anesthesia is both a science and an art, and some would say that the art component comes even more into play in obstetric anesthesia. So today I'm going to look at recent international practice guidelines on the care of the obese pregnant woman and how they relate to anesthesia and the evidence that supports them. So all these obstetric organisations have practice guidelines specifically for the care of obese pregnant women, and they relate to before, during and after delivery. So we have the International Federation of Obstetricians and Gynecologists, the Canadian Society, the UK College, the Australian and New Zealand College, the Danish Society and the American College. So being practice guidelines, they all come with some kind of level of evidence quality assessment to specify the quality of the evidence that supports their recommendations. And so I think before we look at the recommendations, it's useful to look at the language that is used to describe the level of evidence. And one of these systems of categorization is the grade system. And so if we just take notice of the language here, so if we're a low level of evidence, it means that we have a low level of confidence in the estimated effect, or a limited level of confidence. And so let's have a look at what is in these guidelines that is of particular relevance to us as anaesthetists. So if we look at the 6 guidelines from the 6 organisations, so all of the guidelines recommend assessment by the anaesthetist in the antenatal period. And the quality of evidence supporting that is considered low level, expert opinion. All of the recommendations include something about equipment, staff and models of care. The majority mention early epidural insertion, although there's varying levels of insistence, and the quality of evidence for this is actually higher than that for the antenatal obstetric anaesthetic appointment, but still considered low. There's evidence regarding antibiotic dose, mentioned in some guidelines, but a little bit of diverse opinion about the antibiotic dose. Comments about airway management in 2 and IV access in 1. So I'm going to talk about the top specific details, and there are parts of this where there's overlap between the different sections. And so just from that first little run through, you can see that there is significant variation in the content of these guidelines. In 2019, a systematic review actually examined more closely the range of guidelines that were available at that time. And when considering all of the recommendations, so not just those specific to anaesthesia, but including obstetric and midwifery care as well, the conclusion of this paper was that most of the guidelines were not evidence-based. So a bit of an evidence-free zone, not just for anaesthetics, but across the board. And so I do think we should acknowledge that we're practicing in this area where for many things, we're doing what we think is right without a high level of evidence. But if we look really carefully, I think we can find evidence that allows us to be confident that despite a lack of high-level evidence, that some of these things that we practice and recommend to others make sense and are probably a good thing to do. So in terms of the antenatal consultation, I think we'll all agree that the obese pregnant woman who has a BMI greater than 40 presents challenges to an anaesthetist. And it would seem to me that that alone is a good reason to have an antenatal communication with an anaesthetist. As high-risk patients, I think it's even more important for us to have an opportunity to discuss even the process of getting an epidural in the institution, like how long it takes, who's going to do it for you, how long it might take until that epidural is working, the process of having a cesarean section, given that these women are at a higher risk of having a cesarean, and the increased risks of difficulty with our procedures and the increased risks of having general anaesthetic. I think it also allows a very important discussion around what is difficult for us to achieve, and particularly in situations of urgency, there are limits to what we can achieve in terms of some of our techniques. And those situations of urgency may relate to either the mother or the baby. And I think they're very important discussions to have. So what can we actually say to women in that antenatal anaesthetic consultation? So this was the results of a systematic review really reinforce, I think, what we see in practice. So obesity can be related with epidurals that are difficult to put in, and sometimes they don't work very well. And this is actually good information to bring to the anaesthetic consultation. And I wonder whether, after neuraxial ultrasound has become more widespread, whether the next systematic review and meta-analysis may actually present us with different numbers. Ultrasound hasn't actually made its way into these guidelines, specifically for anaesthesia practice, but I suspect that sometime in the future that it will. It's increasingly used for both vascular access and neuraxial placement. And I think many anaesthetists would already say that this is equipment that is very desirable when caring for patients with obesity. So the potential for multiple attempts and for increased failure, I think, are really important things that we can convey to pregnant women in the antenatal consultation. This paper presents some data from Australia, over 1,400 women having both elective and emergency caesareans with a BMI range between 17 and 66. And they demonstrated that, again, as we've probably observed, that as BMI increases, so does surgical time, anaesthesia time, and the overall theatre time. And again, in terms of bringing information to the antenatal clinic, potentially this is information that helps us decide whether we're going to discuss a single shot spinal or a combined spinal epidural in this context. There remains very little specific literature about the effectiveness of the antenatal anaesthetic consultation for pregnant women with obesity. So an audit survey was undertaken in the UK and repeated, so between 2005 and 2019, and they suggested that the facilitation of these appointments, specifically counselling regarding obesity, had increased over that time period. We did this small observational study published in 2014 that showed that that specific appointment discussing obesity didn't change anxiety levels in the women, but did reduce their decisional conflict about whether or not they would have an epidural in labour. But I think the antenatal anaesthetic consultation for women in obesity is an intervention that makes sense. It's not only likely to help us as anaesthetists, but also help the women. In terms of the recommendations around equipment and staffing, there is some evidence to support these practical recommendations. I think it's really important to check that the operating table will support your patient, not just in the supine position, but in the lithotomy position. Because unlike other types of surgery, emergency surgery, it's important in the obstetric setting to be able to rapidly get into the lithotomy position, either to facilitate a vaginal delivery or to evaluate and manage the causes of blood loss. There are also some recommendations around having senior staff present. We have to make sure that we have the right gear for intubation. We need the right size blood pressure cuffs and potentially invasive monitoring. And of course, in some instances, we will need those long needles. This retrospective observational study of over 24,000 women showed that, again, anaesthetic time and surgical time were longer in patients with a BMI greater than 50. But importantly, there was an association between the presence of senior staff, both obstetricians and anaesthetists, that reduced both the anaesthetic and the surgical time. So we need the right staff, senior staff with experience. And I think all of us as anaesthetists have experienced that time where you were hoping to get in an epidural or a combined spinal epidural, and all you could get was a spinal. And having that senior surgeon present at that time is extremely important. And we might just get away without that general anaesthetic at the end. In terms of equipment approach to the airway, This brand new multi-center study out of Michigan, published in Anesthesiology this year, tells us again that we need to be well prepared for managing the airway, particularly in the obese pregnant woman. So they looked at over 14,000 women and have suggested a rate of difficult intubation of 1 in 49 and failed intubation of 1 in 100. Very interestingly, though, so the main risk factors were increased BMI, and then all those other things that we evaluate in all our other patients, things around mouth opening, thyromental distance, and neck extension. So again, that obesity coming up as a risk factor for difficult and failed intubation in obstetrics. So we know that the different approaches that we can use to improve our lot are ramping, which improves both the laryngoscopy and ventilation. And we can do that either with the actual bed, with ramping devices like the troop pillow, or just with a pile of normal pillows. We can do head up tilts. So it's been demonstrated that head up tilt increases apnea time in non-obstetric patients by increasing their FRC. It may not quite have the same effect in pregnant women, but I still practice this because I think we tend to need all the help that we can get. In terms of high flow nasal oxygen, I think we had great hopes for this, but in pregnancy, it hasn't been shown to be as impressive as we first thought, with this RCT showing that high flow nasal prongs was not as good as 15 litres per minute through a tight fitting face mask. And it was postulated that that was due to air entrainment from mouth breathing. And as it turns out, just breathing through your nose and with a closed mouth was actually quite poorly tolerated, particularly in this pregnant population. Video laryngoscopes, I would definitely say yes. And this kind of connected to the next slide. So hypoxemia has been shown to occur quite commonly during the induction of pregnant patients. So one study here from France and one from South Africa. The South African one showing an incidence of 16%, slightly different cutoffs, but 20% from the French study. But in both of these studies, less than 3% of the practitioners used a video laryngoscope. There were some conflicting results here regarding BMI, with the French study suggesting that a high BMI was less likely to be associated with desaturation, and the South African study showed the reverse. This may have been due to the fact that in the French study, over 50% of the operators were not experienced, having less than 12 months experience in anesthesia. So it may be related to preparation and position. In terms of blood pressure management, we know that patients with large arms and arms with a difficult shape have difficulty with non-invasive measurements. And this has problems not just during our care of the patient, but in the antenatal period, when accurate blood pressure measurement is so important for risk management during the pregnancy. And we know that if we use the wrong cuff, then people can be misdiagnosed with pregnancy-induced hypertension antenatally, and that may get them more blood tests, more anxiety, medication they may or may not need, more appointments, and probably significant stress to the mothers. And I think we need to accept now that some of our equipment is just not fit for purpose. We found that in 450 women who came to our antenatal clinic, that 16% of women would need a Welsh Allen large cuff, and a small 2% would require the thigh cuff placed on the arm. And that's according to the manufacturer's recommendations. But you and I both know that sometimes the soft tissue in the axillary region and the region around the arm may be so significant that neither of these cuffs can actually be secured or operate adequately. And we showed similar data from KK Women's and Children's in 300 women, showing that 0.3% required an extra large cuff, referring to a different manufacturer of cuffs. And so I think we would all agree that at the point of providing neuraxial analgesia or anesthesia, even more so anesthesia to obese pregnant women, this is a time when we really need accurate blood pressure monitoring, both for the safety of the mother and the perfusion of the baby. And invasive arterial monitoring is the obvious alternative, but it's not completely without risks. And so this is why there's been a bit of interest in these continuous non-invasive measurement devices, such as the ClearSight or NextFin. And this, in a recent Japanese study, was shown to show good accuracy and trending in non-obese patients undergoing elective cesarean section. And of course, in the non-obese patients, they compare that to a properly fitting non-invasive blood pressure cuff. We don't really know how these finger cuffs perform in the obese setting, and it probably requires a comparison to an arterial line in order to demonstrate that. And I know that Ban Lang has done a lot of work using this device. So let's now look at antibiotic dosing for prevention of wound infections. So we know obese women have an increased rate of wound infection, and the guidelines that I present here are in a little conflict about whether we should have a higher dose of pre-incisional antibiotics and at what threshold that higher dose should kick in, whether it should be based on body weight or body mass index, and if so, at what level. So we published this pharmacokinetic study that showed that in patients with a BMI greater than 35, that repeat dosing would be needed if the skin was not closed at 2 hours. And that was regardless of whether the first dose was 2 grams or 3 grams. And so the point of contention in this area is related to how the levels of antibiotic are measured. So at the tissue level, some studies mash up the fat tissue and then measure the antibiotic level in that, and then at the same time measure the serum levels. But it's actually known that that's quite inaccurate depending on the vascularity of the adipose tissue. So we use the gold standard, which is microdialysis catheters that measure the interstitial fluid concentration of antibiotic. But of course, what neither of these techniques will actually tell you is if the certain dose actually has a clinical effect in reducing wound infection. And some large prospective randomized studies are probably required to demonstrate that. So in Australia, the therapeutic guidelines make the recommendations on surgical antibiotic prophylaxis. And since 2019, for all types of surgery, not just obstetrics, they've recommended that if the weight is above 120 kilos, that 3 grams of cefazolin is warranted. And that's really based on small pharmacokinetic studies such as ours, but also the safety and low cost of that drug as a prophylactic agent. And so of the guidelines I listed, so the Danish Society actively recommends that increased dose, and those other 3 listed there mention it, but don't make a firm recommendation. So in conclusion, I think it's really excellent that our anaesthetic practice components are included into the international guidelines on obesity and pregnancy. And I think despite generally a low level of evidence supporting these recommendations, I think that researchers within obstetric anaesthesia have tried very hard to examine closely some of our practices and whether or not they have a positive impact on our patients. And I think we can find this evidence that makes us confident in what we're doing and what we recommend to other people. So thanks very much for listening today, and I look forward to hearing the other speakers.
Thank you. Thank you, Victoria, for this very clear talk. We have some questions from the audience. And the first one, we have time for a few little questions. And the first question is, how early should we insert epidural in obese parturients?
Yes, so this is a really interesting question. And obviously, this practice is the coming together of our wishes and the woman's wishes. Clearly, we can't do an epidural if a woman doesn't want one. And there's probably a lot of differences in cultures around the world about how that relationship and that tension between the patient and the doctor and what each of those want or would recommend and how that plays out. So look, I think the woman needs to be in labour or have a plan to get into labour. So we would do some pre-induction epidurals prior to the commencement of rupture of membranes or start of oxytocin infusions. And again, I guess the things that we do in our practice is also affected a lot by our cooperation with midwives and obstetric staff. And how they may recommend the epidural to a woman. But I think what we're trying to achieve is to insert it at a time which is favourable to us and will optimise our success and therefore hopefully the satisfaction of the woman with our pain relief, and will serve us well if she comes for a cesarean.
Thank you. Another question is that is our obese patients is ERAS protocol possible in obese patients?
Right. Look, yeah. So look, I think the components of the ERAS protocols are relevant to all women. But they may be easier to achieve in some rather than others. And I think if we have consistent, again, a bit like the early epidural, if we know what we're trying to achieve, optimizing fluid management, minimizing fasting, optimizing analgesia and mobilization, then regardless of the population we're trying to do that in, we do our very best for each of those components.
It's perfect. There's another participant who is asking how often you need to insert central line for the obese patients.
That wouldn't be a routine practice at our institution. I think for the most part, I guess you may be asking in the relation of difficult IV access. That is, of course, a point of recourse in any patient, in any context, sometimes. For the actual purpose of having central access over peripheral access, almost never, as long as that solid peripheral access can be obtained.
Okay. And the last question is, do you use microcapnography to control hairline and airway?
I do not, but I would like to hear about that if someone wants to send me an email or a message.
Okay. Thank you so much, Victoria. And now we will have the pleasure I have the pleasure to introduce Prof Ban Lang from Singapore, and is a specialist for post-surgical and childbirth pain and psychological vulnerability factors in childbirth, and is developing an analgesia delivery system in obstetrics. Please, Prof Ban Lang, you will speak us about Remy Fentanyl for labor analgesia.
Thank you, Chairman, for the introduction. So I just want to confirm that things that you can hear me okay, and things that you can see the slides.
Yes.
Okay, thank you very much. So yeah, thank you, Chairman, for the kind introductions. So good afternoon. First, I would like to thank Dr. Susilo and the organizers for the invitation to participate in this Indo anesthesia via this virtual platform. So my task today is basically to discuss about Fentanyl for labor analgesia. So my name is Ban Lang. I'm from KK Women's Insurance Hospital, and it's one of the hospitals in the Sing Health UNUS Academic Medical Center in Singapore. Okay, so I don't have any financial conflict of interest. Just to say that one of the projects that I'll be describing is actually funded by the Sing Health Foundation grant. So this is where I work. So it's KK Women's Insurance Hospital. So it's a tertiary maternity and pediatric hospital with the iconic women's insurance towers. So you can also see on my background at the back. A very nice building that was actually started its operations in 1997. And before that, we were actually situated across the road. And back in 1966, actually KK Hospital, which was known as Kedang Kebal Maternity Hospital, actually was actually in the Guinness Book of Records for the most number of births in 1966, which is the year after our founding of Singapore, of almost 40,000. So obviously, we don't have that number now. Currently we are having about 12,000 childbirths in the hospital per year. We have a 25% cesarean delivery rate, and we administer about 5,500 labor epidural administrations. And for the purpose of this talk, KK Women's Anesthesia actually administers about 40 to 50 PCIA Remy Fentanyl administrations. And this is part of the work that we've been doing for the last few years. So in terms of the options for labor analgesia, so we know what is the gold standard. It is obviously the epidural analgesia. So, however, there are some problems. First, in some centers, it may not be always available. It may be declined by patients for whatever reason, or it may be contraindicated because patients may have, for example, thrombocytopenia, coagulopathy, or even sepsis that would have contraindications to epidural analgesia. So traditionally, in terms of labor analgesia, the delivery suites would have other options, would include nitrous oxide in terms of Entonox, and also the use of intramuscular pethidine and other options, including non-pharmacological options. So today, we will look into Fentanyl, and there will be two areas that I'll be looking into specifically, including the quality of pain relief and also the adverse effects in terms of the effects on the mother and the fetus compared to other forms of pain relief. So in my personal opinion, and that's meant for discussion, is whether we think that patient-controlled intravenous analgesia or PCIA Fentanyl should be considered as the second option after epidural, and before the rest of the above mentioned techniques should be considered. So let's start off with what is Fentanyl. So basically, it is a synthetic mu opioid receptor agonist. And it is special because of its very fast onset and offset of effect, with a very short blood-brain equilibrium half-time of 1 minute and a context-sensitive half-time of 3 minutes with an infusion. And the reason is because of its rapid metabolism by a non-specific plasma and tissue esterases. The drug actually crosses placenta, but however, it is rapidly metabolized and redistributed, and therefore it causes minimal reduction in ABGA scores. And things that is found that a single dose of 1 mic per kilobolus may cause mild neonatal depression. So as with all opioids, the effects are reversed by naloxone. So that's probably something that the neonates would be aware of. And the dosing of Fentanyl is basically has a similar potency as fentanyl. And it is given as an intravenous administration. And specifically, it is will be given as a patient-controlled intravenous analgesia. So these two figures is to show the wide variation of uptake of analgesia in our practice. So for epidural rate in vaginal deliveries, it could actually range from less than 10% to more than 80% in some developed countries. And so with the use of intravenous analgesia rate Some countries actually would have the range between about 20% to 50%, including in France, the UK, Israel, the United States, and also Belgium. So there's a huge range of practice of using intravenous analgesia. So in KK, it is not so commonly used. So in terms of other information about opioids used in labor analgesia as an alternative, it is actually used in many obstetric units in the UK, France, and Belgium, and it is in a rate of between 30% to 50%. And of note is that remifentanil is the first choice of opioid of PCA in all 3 countries. And it's due to the modest analgesia that it affords in the first stage of labor and also gives some pain relief in the second stage of labor. So this is very important because the PCA remifentanil, the safety and the efficacy of it is actually in part determined by the dosing regimen, and these would be the common ranges that most of us will actually use. So for remifentanil, I think that the dose range will be between 20 to 50 micrograms, and the highest mean dose will be about 0.7 mics per kilo, and this should not be exceeded due to the risk of oxygen desaturation and also sedation. So the lockout period is between 1 to 3 minutes, and usually we time it to the uterine contractions that the patients may actually experience. And of contention, I think that is the use of the continuous infusion, which is usually between 0.025 to 0.15 mics per kilo per minute. So what I'll probably say is that many centers would tend to be more conservative, and rightfully so, basically due to the caution of the opioid effects of respiratory depression and potential cardiopulmonary arrests. So let's start basically with some early studies that compared between remifentanil and Entonox or nitrous oxide. So this first study basically compared between remifentanil and Entonox. So at least in the short term of 1 hour, remifentanil, which is depicted in the black color box, actually has lower pain scores consistently compared to nitrous oxide. So remifentanil is actually found to be more effective with a lowering of pain scores of 1.5 compared to nitrous oxide of 0.1. And remifentanil is actually preferred by most parturients. And this could be due to the sensation of discomfort being reduced by euphoric and sedative and anxiolytic properties of a mu agonist. However, remifentanil is associated with a higher incidence of sedation and lower saturations in the patient. There is no difference in maternal blood pressure or heart rate, and there's also no difference between fetal heart rate abnormalities and also APGAR scores. So next, let's go to comparison between remifentanil and other forms of opioids. So pain scores are actually similar in this trial between pethidine, remifentanil, and fentanyl in labor. Another study that compared between remifentanil and pethidine showed that remifentanil was associated with higher patient satisfaction with no difference in oxygen saturation. And furthermore, due to its shorter duration of action, remifentanil had better neurological and adaptive capacity scores in the neonate. So comparing between remifentanil and PCA fentanyl, so both are actually effective in this trial. However, remifentanil is associated with a higher incidence of oxygen desaturation. So this trial used basically remifentanil with both bolus and also a background infusion. So that could actually be one of the reasons, and therefore the background infusion would need to be considered very carefully. And in this trial, fentanyl was actually only given as a bolus of between 25 to 50 micrograms with no background infusion. However, despite this, fentanyl was associated with a higher incidence of neonatal resuscitation requiring back and mask ventilation, and also some cases of intubation with no significant difference in cord pH. So in terms of meta-analysis, things at our department in KK, we basically did a systematic review that compared between remifentanil and pethidine for labor analgesia in terms of pain relief in the first hour of administration, and found that remifentanil had better pain scores. And this is corroborated with a latest study that included more studies and also found that basically that remifentanil had better pain scores compared to pethidine. We know this study very well, which is the RESPITE trial. Things that so basically it was actually comparing between PCA remifentanil only using bolus of 40 micrograms with 2-minute lockout versus intramuscular pethidine of 100 milligrams. The primary outcome of this study was the proportion of women who received epidural or required conversion. So the remifentanil group had a conversion rate to epidural of 19%, whilst pethidine had a conversion rate to epidural of 41%. Of note, there is no serious adverse events or drug reactions. And the conclusion is that remifentanil halves the epidural conversions compared to the use of intramuscular pethidine. Now going on to comparing between remifentanil and, of course, our gold standard epidural analgesia. So this is a summary chart of the studies of patients with pain score before the intervention and also after the intervention. So for the bottom line, which is for epidural, things that the pain scores actually reduced by about 75%. And for the rest of the studies which depict remifentanil, the pain scores come down between about 10% to about 60%. And many patients actually require other forms of analgesia as supplementation. And there's actually a high conversion rate in overall, about 40%. So these are comparing between remifentanil and also epidural in this randomized controlled trial, in which things that the rate dot is actually remifentanil and the blue color dot is actually for epidural. Consistently, remifentanil was actually inferior in every time point with a difference in on average of more than 1.5 units. So satisfaction score, however, is not different. Remifentanil is actually known to have lower saturation and also more episodes of apnea. And in terms of satisfaction, things that this randomized multi-center equivalence trial found that satisfaction score was lower with the use of remifentanil compared to epidural analgesia. So I'm going to come on to something which is very important, which is about the safety and balancing that with the efficacy. So what I'll say is that there's an intricate balance of the safety and efficacy of remifentanil for labor analgesia. So the safety concerns are on the potential cardiac arrest following respiratory depression and oxygen desaturation, and hence one-to-one midwifery care, which is going to be labor intensive, may actually be required. And the delivery suite should be equipped with resuscitation capabilities. And the efficacy of remifentanil as labor analgesia is very challenging because there's always a need for dose optimization with often dose escalation as labor progresses. There are actually several case reports that highlight the potential problems of having respiratory depression and the potential cardiopulmonary arrest. For example, in this case, with a patient on 40 micrograms bolus with no basal infusion, there was actually sudden cyanosis and respiratory arrest. However, this was actually circumvented with ventilation using a self-inflating bag. The next point is that this second case highlights basically the synergistic effect of concomitant depressant analgesic medications, for example, like codeine or the use of IM diamorphine together with nitrous oxide. And this could actually be a very bad combination to be used with remifentanil. So in light of these several case reports of respiratory depression and cardiopulmonary arrest, an editorial by Mark had concerns with extreme caution with administration of remifentanil and suggested that one-to-one midwifery care with continuous observation of the vital signs is extremely important, and also suggested the concerns of the safety on the use of remifentanil as labor analgesia. So I just want to point out some salient points about these cardiopulmonary arrests is that it can happen even if dosing is within the recommended range. And in most of the cases, there are actually multiple contributing factors, and therefore we have to be having a good risk assessment for the patients that we put on if we choose to use remifentanil. And the bottom line is this: we should be able to do continuous respiratory rate monitoring, whether it's going to be through manually or using end-tidal CO2, and also oxygen saturation monitoring, and have readily available resuscitation equipment in the delivery suite itself. And it is highly advisable and somewhat mandatory for one-to-one nursing or midwifery presence in the delivery suite room. So given the wide use of Remi Fentanyl, the Remi PCA Safe Network is established in 2009 by Dr. Andrea with the goals of improving the safety for Remi PCA. So the network actually has several components of continuous quality control, collective learning and experience, and also concentration of the know-how of administration of Remi Fentanyl. And as of last year, the central database multi-center actually had 12,500 cases, and there's actually regular evaluations of these pooled data for improvements. And KK is actually very proud to actually contribute to this database to improve the safety and actually lead to this pooled knowledge within our community of practice. So going on to some innovation portions. So in terms of the use of the PCA, the question is that to be responsive to a participant's needs, things that perhaps instead of using a fixed dose, perhaps some variable dosing regimen is required, okay? And sometimes continuous infusion may actually be required because things that the pain will actually increase with advancing labor. And perhaps at some point, a basal infusion may actually be beneficial to the patient. So our center at KK has proposed a vital signs controlled patient-assisted intravenous analgesia, or VPIA Remifentanil. I'll just quickly go through in this diagram. So the system uses incremental Remifentanil bolus dosing when there's an increased demand on the patient during a monitored period, and decreasing demands bolus dosing when there are actually fewer demands. And next, if the maximum bolus of 50 micrograms is actually reached, the continuous infusion would then be started. And of course, what we want to do as a closed-loop system is to enable a safety mechanism to temporarily pause the pump and to de-escalate the dosing regimen when critical vital signs parameters are actually breached. So this is the pump setup. So this integrated pump has the components of a PCA handset with a pulse oximeter and also a respiratory sensor. So the closed-loop system monitors the analgesic demands and titrates the dose according to the need, as I've mentioned before. And the system continuously monitors the vital signs. So if the predetermined critical values are being reached, the pump will be paused and subsequently stepping down of the Remifentanil dosing to reduce the risk of overdosing and adverse events due to Remifentanil. So in a case series of 29 patients, 16 patients utilized the infusion phase, which is depicted in the blue continuous line. And the bolus-only group is indicated in the red broken line. And there's improvement as what is reported previously with the use of Remifentanil is that there's actually improvement of the pain in the initial hour. But we observed that for patients who had an infusion, that the pain scores return back to the baseline. But very interestingly, after the use of 4 hours, both groups actually have similar pain scores. And there's no difference in terms of oxygen saturation, pain scores or satisfaction scores between the infusion and also the bolus-only group. So in terms of safety, things that we actually put the patient on some oxygen supplementation and also with the monitoring. We found that about 52% of patients actually had some episodes of oxygen desaturation, and also 24% actually had some maternal bradycardia. However, all of these episodes recovered spontaneously within 3 minutes without a need for intervention. So I would like to just summarize here things that so we are actually not talking about the use of Remifentanil as a gold standard. What we are trying to say here is that perhaps that's a good alternative number 2 that we should consider. However, in summary, there are some points that we need to know about the use of PCA remifentanil, which is that it is less effective compared to epidural analgesia, and that we know. In terms of patient satisfaction, I think generally patients are satisfied with the use of remifentanil. A lot of times things that we may actually need some supplementation in terms of nitrous oxide, and be very careful of combining depressant analgesics with the use of remifentanil. And some patients actually may require conversion to epidural. This next point is very important, which is actually that there should be careful monitoring and preferably one-to-one midwifery care to detect and to treat maternal bradycardia, oxygen desaturation, and any potential respiratory depression. However, these episodes, most of them are actually self-limiting. And what I think would be the future of care in remifentanil is that we will need to improve on our safety, efficacy, and we will need to individualize our treatment of remifentanil to our patients. So I'd like to acknowledge the research team and also my collaborators in the hospital. And of course, I'll just wish everybody well and take care during this pandemic. And I leave my email address here if anybody wants to have any further discussions about PCA remifentanil, which I feel very passionate about. So this is my last slide, which is that the World Congress of Anesthesia is in 2024 and actually will be held in my home country in Singapore. And hopefully we will be able to see each other face to face. With this, I thank you.
Thank you. Thank you very much, Prof Ban Lang. We will be in Singapore, sure, and it will be a very great time to meet face to face. The session is very interactive, and we have a lot of questions from the participants, and I will ask one or two questions, and perhaps Victoria and you can answer to other questions directly in the chat. The first question of participants is, can we give remifentanil without background infusion, and will it reduce the risk of sedation and desaturation?
Okay, so maybe I'll just give a bit of the practice that I have in the hospital. So actually for us, things that we do not, so I think we only administer about 40 to 50 administrations. So generally for our hospital, it is actually when there's actually contraindication or when the patient absolutely declines having epidural analgesia. So epidural rate is very, very high, which is what we want to encourage. However, we do know that for some patients, they may have some concerns, and we do then administer remifentanil. So what we do is that we actually have a 24-hour on-call team. Things like that. I'm actually in the hospital right now. Things like that, and I've actually got my on-call team with us. Things like that. So we actually administered remifentanil actually with a 24-hour standby team. So I think that's very, very important. Okay. The next thing is that when you actually give this remifentanil, you actually have to give it in a dedicated line, or at least a one-way valve to ensure that there's actually no reflux. I think that's very important. The next portion is that you probably need to spend some time in the delivery suite, because what's important is the dose titration. So we do allow remifentanil to be given in early labor all the way to advanced labor. That's actually not a very big problem. But what I think is very important is actually the dose titration, so that the patient will be somewhat comfortable. I think patient expectation of remifentanil needs to be obviously be moderated, because it obviously cannot be as good as epidural analgesia. I think that point is very important. The next portion is about the midwifery care. So things that we try our very best, and things that to actually give one-to-one midwifery care, and we put the patient on continuous saturation monitoring, and increasingly things that we are actually including end-tidal CO2 monitoring. This for us in KK, we actually give remifentanil with some supplemental oxygen. So that's also a portal for us to actually get end-tidal CO2, but in terms of having respiratory rate monitoring for the patient. So I think these are the important criteria, and we have actually set a standardized protocol, which is actually specific to our department to ensure that basically the obstetrician, the midwife and also the neonates are very, they know the fact that the patient is on Remy Fentanyl, and they know how to react if there are any adverse events that occur. So I'll probably say is that the most common effect that we actually get is that patients are having nausea. So that happens in about 10 to 15% of the patients that we have given. Thank you.
And that is another question. The remifentanil infusion is managed by anesthesiologists, and you always have anesthesiologists in standby in your hospital.
Yes, correct.
And what about the hospitals and units where anesthesiologists are also for emergency unit or surgery? What about that? Do you think that midwives can manage this remifentanil infusion?
Okay, so I think that to me is a controversial area, because I've actually been in this asked this question before. So what I'll probably say is that I think it is probably, at least in my center, we think that having an anesthesiologist on duty, specifically in the delivery suite, is actually very important. Because I think as with what has happened in the various case reports, sometimes it could actually be a very sudden desaturation. So that's what we hope not to get. We don't really have any in this hospital. So what I'll probably say is that I think having basically skilled hands that are able to handle the airway and know the pharmacokinetics and pharmacodynamics of the drug would actually be important. So I do not have any particular experience in terms of how you'll be done in the hospital, but what I'll probably say is that it is probably best to actually have anesthesiologists on standby to ensure that basically if there are any untoward things that happen or potential adverse effects with remifentanil, this can be addressed expediently. Thank you.
So your system, your feedback system could be a first safety system, and you recommend anesthesiologist in standby for all remifentanil infusion. Is that your message?
Yes, correct. So I think for KK, we are very lucky because we are a maternity hospital. So of course, that we actually have anesthesiologists on standby 24/7. So we are very fortunate. But I think that's also one of the reasons for why we are more confident in delivering this care, because we know that we are able to actually be able to address the patient's needs, and also if there are any issues that arise, even if it's very, very sudden. Thank you.
Okay, thank you very much. And I now will introduce Prof Frédéric Mercier. Frédéric, can you suppress? So you are muted. So now it's okay.
Yes, now I am unmuted.
It's my pleasure to introduce Prof Frédéric Mercier from Antoine Béclère Hospital in Paris, in France. Frédéric is the past president of the French Society of Obstetric Anesthesia, CARO, and the past president of European Society Obstetric Subcommittee, and is an international expert and researcher on spinal induced hypotension in cesarean section. And he will focus today on the use of norepinephrine to restore hemodynamic in this context. Frédéric?
Thanks for this kind introduction, Anne-Sophie. We are going to launch my presentation because I have an unreliable internet connection with my smartphone, and then I will answer live the question and that will be provided. Please, Chrisa, can you launch the presentation? Good afternoon. I want first to thank Cecilo and his great team too for inviting me again at this Indoanesthesia meeting. And I hope to see the next Indoanesthesia in 2023 coming back again as a face-to-face meeting as formerly. My topic today is hemodynamic control during spinal anesthesia for cesarean section, focus on noradrenaline use. This is my potential conflict of interest with Aguetan Company. There are many definitions of hypertension in the literature, but a decrease in systolic blood pressure by more than 20% from baseline value is most often used. This single criterion is also the one we selected in the international consensus statement we published with Mike Kinsella as first author in Anesthesia in 2018. Spinal-induced hypertension is extremely frequent during elective cesarean section performed under single-shot spinal anesthesia, from 50% up to nearly 100% when not actively prevented. Consequences of hypertension are multiple. For the mother, mostly nausea and vomiting, often accompanied by dyspnea, but more symptoms can occur up to cardiovascular collapse and myocardial infarction. For the baby, it is mainly acidosis with a low umbilical artery pH, but with more severe and or prolonged hypertension, it can go as far as neonatal ICU admission, cerebral palsy, or death. It is really important to understand the main mechanism of hypertension during spinal anesthesia. For that, as shown on this formula, keep in mind that blood pressure is broadly the product of systemic vascular resistances by cardiac output. During single-shot spinal anesthesia, there is a very rapid and huge decrease in afterload because of a quick onset of arterial vasodilation. But contrarily to what was thought long time ago, there is little decrease in preload and venous return, at least initially, because venous vasodilation is moderate and its onset is quite slow. Thus, cardiac output is maintained and even increased initially at onset of spinal anesthesia. And therefore, the decrease in blood pressure is only due to a decrease in systemic vascular resistances, not to a decrease in cardiac output. You can see on this slide the main tools for prevention and treatment of hypertension that have been described in the literature. Vasopressor use is the cornerstone of this modern management. This is logical to counteract the immediate and huge decrease in systemic vascular resistances I just detailed before. On the other hand, fluids and caval compression prevention cannot alone prevent hypertension because they do not act on these systemic vascular resistances. However, they can help decreasing hypertension severity by improving venous return and thus preserving maternal cardiac output that otherwise may also decrease, but more lately. As I mentioned already, in January 2018, we published an international consensus statement on the management of hypertension with vasopressors during cesarean section under spinal anesthesia. Two key recommendations were the prophylactic use of vasopressor straight after intrathecal injection and the use of an alpha agonist with phenylephrine recommended at this time. Indeed, there was only 4 studies on noradrenaline use available versus 35 studies to support phenylephrine use. Nonetheless, even at this time, we mentioned that vasopressors with a small amount of beta agonist activity, like noradrenaline, could have the best profile. Where are we today in March 2022? We have 4 years of additional literature and about 30 studies now on noradrenaline during cesarean section, challenging the phenylephrine use. Overall, as you will see, the literature on noradrenaline use looks convincing. Let's start with the first landmark randomized controlled trial that appeared 7 years ago. This study was performed by the team led by Warwick-Nanki, whose research promoted the use of phenylephrine instead of ephedrine during the 2 preceding decades. With a closed-loop computer-controlled device set to maintain systolic blood pressure at 100% of baseline, the authors compared noradrenaline diluted at 5 micrograms per ml to phenylephrine diluted at 100 micrograms per ml. They found, as expected with this closed-loop feedback system, no difference in systolic blood pressure, but also no difference in stroke volume. Conversely, cardiac output was roughly 10% higher with noradrenaline, and this was due to higher heart rate only. Although there was a much lower incidence of bradycardia, 18% with noradrenaline versus 56% for phenylephrine. Regarding neonatal arterial blood gases, they found no differences between the noradrenaline and the phenylephrine groups. However, they reported significantly higher venous pH and higher venous oxygen content in the noradrenaline group, although these differences were slight and not clinically relevant for these healthy babies. But much more interestingly, and this is often overlooked, they also reported a very unexpected result regarding neonatal concentration of catecholamines. Indeed, not only adrenaline, but also noradrenaline umbilical concentrations were markedly lower when the mother had received noradrenaline instead of phenylephrine. These umbilical catecholamines looked mostly endogenous, I mean produced by the fetus itself, because obviously their levels were much higher in the umbilical arteries than in the umbilical vein. This is well discussed here by Warwick-Nanki and colleagues in their articles. Catecholamines, such as adrenaline or noradrenaline, do not readily cross the placenta. Note that this is very different from ephedrine, which crosses freely the placenta. Thus, the lower umbilical catecholamine concentrations found in this study likely reflect differences in fetal catecholamine production. Fetal catecholamine levels have been shown to be greater with increased stress during delivery and fetal asphyxia. The logical overall deduction is that lower umbilical catecholamine concentrations, together with greater umbilical vein pH and oxygen content in the noradrenaline group, suggest a decreased fetal stress in this group compared with the phenylephrine group. And this could be related to greater uteroplacental oxygen delivery. In view of this very sound data from Warwick-Nanki and colleagues, you can easily see now why I would disagree with this recent editorial challenging noradrenaline use. Indeed, the parallelism made by the author between ephedrine and noradrenaline regarding potential adverse neonatal outcome because of their beta mimetic effect cannot be convincing. In fact, my view is just the opposite. Most of the current literature support phenylephrine being at best not worse than noradrenaline regarding neonatal acid-base status. We will come back to this neonatal issue later on. 2 years later, the data of this study of Warwick-Nanki et al. Were reanalyzed to focus on another aspect. Using a specific statistical method, the authors showed that the precision of blood pressure control targeted at 100% of baseline was greater with norepinephrine than with phenylephrine. As explained in this discussion of the article, this may be consistent with a quicker onset of noradrenaline over phenylephrine. But mostly, this is fully consistent with the shorter duration of action of noradrenaline over phenylephrine. So next year, in 2018, a first systematic review on noradrenaline use in spinal anesthesia for C-section appeared in the literature. Among 17 records identified, 9 full-text articles were kept for the review, gathering roughly 1,000 parterions. In one of their tables, the author provided interesting information about the main characteristic of these two vasopressors. The molecular structure is similar and the molecular weight is nearly identical. Noradrenaline might have slightly shorter onset, less than 60 seconds, and noradrenaline has a much shorter offset due to a much shorter half-life, 1 to 2 minutes instead of 5 minutes for phenylephrine. The relative potency is around 1 to 13 rather than 1 to 20. It is also suggested that noradrenaline placental transfer is likely minimal as for phenylephrine for the reasons I mentioned already before. And the undesirable fetal metabolism stimulation, which is already low with phenylephrine, contrarily to ephedrine, might even be lower with noradrenaline. One interest of this review is also to provide several tables summarizing each of the 9 noradrenaline studies with regard to their methodology and results, as you can see, for example, on this slide. The authors concluded at this stage that noradrenaline looked a promising alternative to phenylephrine. However, before advising for its routine use, more high-quality studies were warranted. Since then, many new trials on noradrenaline use have been done, and 3 systematic reviews and meta-analyses have been published at least. This one, coming from the group of Fitzgerald and colleagues, did not focus specifically on noradrenaline. 109 studies were assessed with over 8,000 parterions and 12 different methods of prevention that yield 30 direct comparisons. Noradrenaline was found to rank ahead of phenylephrine regarding effectiveness. In addition, phenylephrine caused more bradycardia and ephedrine caused lower umbilical artery pH. This meta-analysis of Michael Heason and colleagues, in which I was also involved, focused on randomized controlled trials directly comparing phenylephrine to noradrenaline. We identified 30 studies, including roughly 2,000 patients. We mainly found no difference in fetal acidosis in the 4 studies that had a low risk of bias and a low risk of confounding. No difference in hypertension too, but less bradycardia with noradrenaline in 2 studies only, and a higher cardiac output with noradrenaline in 2 out of 3 studies. The group nevertheless concluded that the evidence so far was too limited to support an advantage of noradrenaline over phenylephrine. And in fact, the group raised concerns of a deleterious effect of noradrenaline about fetal acid-base statue. This reluctancy toward noradrenaline was namely based on this letter to the editor commenting the results of a dose-finding study of intermittent IV boluses of noradrenaline, but with no comparison to phenylephrine. In this letter, Cooper rightly noticed that 6 out of 33 neonates had an umbilical artery pH below 7.20, thus some fetal acidosis. This was unexpected because, as I just mentioned before, none of the 4 randomized controlled trials directly comparing noradrenaline to phenylephrine on this fetal outcome had retrieved such side effects. In reply, it was pointed out that the fetal acidosis was mild, as all umbilical artery pH were above 7.10, but the authors honestly acknowledged that they had no satisfactory explanation for this unexpected low pH. The only randomized controlled trial I am aware of that reported better pH with phenylephrine than with noradrenaline is this one published in Anesthesia in 2019. Of note, the 2 vasopressors were used reactively by boluses to rescue hypotension, and the relative potency ratio used was not optimal, 20:1, favoring phenylephrine over noradrenaline. Also, the primary outcome of the study was not fetal outcome, but rather incidence of maternal bradycardia that did not achieve statistical significance, 38% versus 22%, obviously because of an inadequate power of the study. As secondary outcome, they found lower umbilical artery and umbilical vein pH, lower in the noradrenaline group and lower base excess 2, but without difference or even a trend in higher incidence of true neonatal acidosis. Here, 13.3% in the noradrenaline group versus 15.6% in the phenylephrine group. On the other hand, the lack of detrimental effect of noradrenaline on neonatal pH is further strongly supported by several dose-response studies that found not any detrimental trends toward lower pH in the groups that had received higher prophylactic infusion rates. For example, here you can see the group N2, N3, and 4 with increasing noradrenaline rates, which had similar umbilical artery pH as compared to the group N1 that has received the lowest noradrenaline infusion rate. This study also suggested that the average noradrenaline rate to set initially prior to adapt it to the individual needs was around 5 micrograms per minute of noradrenaline by tartrate. However, most countries express noradrenaline concentration as noradrenaline base, which is the half part of the drug that is effective, thus giving an average rate of 2.5 micrograms per minute of noradrenaline base instead. In this other dose-response study, again, no unfavorable trend at all towards worse neonatal acid-base statue with these increasing infusion rates of noradrenaline. This latest meta-analysis used a Bayesian network technique. This allows not only direct but also indirect comparison to be made. The author focus here only on vasopressor use, and their primary outcome was specifically the neonatal umbilical artery base excess. Their conclusion was that phenylephrine might not be the best vasopressor and that noradrenaline was less likely than phenylephrine to be associated with adverse fetal acid-base statue. This latest huge randomized double-blind pragmatic non-inferiority study, including 531 elective and 133 non-elective C-section, further supports no detrimental effect of noradrenaline on neonatal outcome compared with phenylephrine. Indeed, umbilical artery pH were similar and, in fact, very slightly better with noradrenaline for both the elective and the non-elective cases, although definitive conclusion could be made only for the elective cases. You may remember in one previous slide, I discussed a study by Mota and colleagues already that at first glance did not appear favorable to noradrenaline as compared to phenylephrine in normal healthy parturient, while using only rescue boluses, however. This new study here by Mota again, this time focus on parturients with pre-eclampsia, half of them being severely ill. Of note, this time, the relative potential ratio they used between phenylephrine and noradrenaline was adequate, about 13:1 instead of 20:1 formerly. And this time, the author found no difference in neonatal pH. In addition, they reported significantly and markedly higher umbilical venous PO2 and oxygen saturation with noradrenaline, as reported by Warwick-Nanki and colleagues initially in healthy parturient. This again suggests that the mal-additional beta-agonist effect of noradrenaline, on top of its main alpha-agonist effect it shares with phenylephrine, helps improving uterine blood flow and oxygen delivery to the fetus. To be fair play, I have to acknowledge that this beneficial effect of noradrenaline over phenylephrine on neonatal parameters was not retrieved in this last study just published in the February issue of IJOA. The population included here was women with fetal compromise undergoing cesarean section. However, again, the two vasopressors were not used prophylactically, but only reactively for hypertension and given as boluses, likely disadvantaging noradrenaline because of its quick offset. In addition, vasopressor requirements are lower in emergency cesarean section performed during labor. This reduces the likelihood to detect differences between the two drugs regarding neonatal outcome. In this recent double-blind randomized controlled trial, has several strengths regarding the debate on potential bradycardic effect of phenylephrine versus noradrenaline. First, it compares manually controlled infusion of the two vasopressors, which is what is usually used by physicians in real-life setting. Second, it is quite a large study involving 200 parturients. It shows clearly the clinically relevant benefit of using noradrenaline over phenylephrine regarding maternal heart rate. As you can see here, both vasopressors are similarly effective at maintaining blood pressure close to baseline, upper right figure 2, but noradrenaline has nearly a neutral effect on maternal heart rate, while phenylephrine produces on average a 15% decrease in maternal heart rate. Here, the lower right figure 3. But more importantly, phenylephrine induces a 16% incidence of bradycardia below 50 per minute, whereas this virtually never occurred with noradrenaline, here 1%. For more detailed information, I suggest this editorial where we discuss our view about the use of noradrenaline in this obstetric setting, and in which we also stress that noradrenaline concentration can be expressed either as a noradrenaline base or as noradrenaline bitartrate, depending on national agency regulations. This confusion regarding the expression of noradrenaline concentration is important, but most often overlooked. Thus, don't hesitate to spread my warning by quoting our editorial. So, what can we retain as summary of potential benefits and issues regarding noradrenaline use during cesarean section? 30 trials have been done at least today, and 3 good systematic reviews and meta-analyses have been published since 2015. Less maternal bradycardia is the main advantage for sure. This is relevant to me and also quite obvious when using it daily. Better cardiac output, here I agree that the clinical relevance remains less clear for the moment. Shorter duration, one study plus some other indirect evidence suggests this may improve precision of blood pressure control and thus decrease the risk of reactive hypertension. At least noradrenaline is as good as phenylephrine on neonatal parameters and maybe slightly better. There is no issue using this low concentration via a peripheral vein, as noradrenaline at 5 micrograms per ml has a similar agonist vasoconstrictive effect as phenylephrine 50 micrograms per ml. And lastly, noradrenaline is available everywhere and is much cheaper than phenylephrine. Therefore, I will conclude that noradrenaline is now a suitable alternative to phenylephrine and very convenient to use with the suggested infusion pump settings written on this slide. This is the vasopressor all our team is using daily since January 2019. And in my view, it may well replace phenylephrine as a first-line vasopressor of choice in the near future. Thank you for your attention.
Thank you very much, Frédéric. We have a very interactive session with a lot of questions, and we will begin with a question about your presentation and perhaps come back to some other question resting for leading from the other presentation to Victoria and Ban Lang. Frédéric, one of the first questions is, in your experience, how does noradrenaline perform in compare with ephedrine?
In both my experience and mostly when looking at the overall literature, there is clearly no discussion. Noradrenaline performs much better than ephedrine, at least for cesarean section that are performed electively. I have to acknowledge, and I didn't address this issue in my lecture, that when considering non-elective cases, because the vasopressor requirements are much lower when the cesarean section is performed during labor, there is not that much differences between the three vasopressors, I mean ephedrine, phenylephrine, and noradrenaline. However, even in this setting, as I showed you, at least for a pre-eclamptic patient, there is some argument to support noradrenaline use over ephedrine and over phenylephrine, mostly over phenylephrine, in the comparative study I show you by Mota in the last issue of the European Journal of Anesthesia in 2021, because although the pH were similar, the oxygen delivery to the fetus was much better with noradrenaline than with phenylephrine.
So it's very, very interesting new data about the neonatal effect. And the question is for the participants that they have access to ephedrine and phenylephrine, and will they ask for which patient, which cases you should recommend to change to noradrenaline first? Is that pre-eclamptic patient only, or do they have to change for all patients?
Well,
we have a selected population.
No, in our practice, we are using noradrenaline for all cases. And this is supported by the data I just showed you during the lecture. However, I have to acknowledge that the differences between noradrenaline and phenylephrine are quite mild, which is not the case when comparing either phenylephrine or noradrenaline to ephedrine, where in elective cases, both phenylephrine and noradrenaline perform much better than ephedrine. So ephedrine, at least in elective cases, should never be used as first vasopressor. It could be useful if you are using phenylephrine as first-line vasopressor to use it as a second-line vasopressor after phenylephrine use if you have a bradycardic effect that is too pronounced. And we have some studies by the group of Singapore showing an interesting device allowing to use phenylephrine first and ephedrine as a secondary rescue drug when there is a too pronounced maternal bradycardia with still low maternal blood pressure. But the other way to handle this issue is to use noradrenaline, because in this case, as I show you, you virtually never have any more significant maternal bradycardia.
And another question is about the fluid management. Is there any influence on the choice of vasopressors and the different fluid management possible?
It's a very good question. I shortly addressed it at the beginning of my talk, but did not detail it because I was focusing on the vasopressor use and mainly on noradrenaline. But yes, fluids are useful, not really to decrease the incidence of hypotension, although they do, in combination with a vasopressor prophylaxis. And this has been well shown by a nice study of the group of Warwick-Nanki combining crystalloid co-loading with phenylephrine prophylactic infusion. But mostly, I think what is interesting in providing fluid co-loading on top of vasopressor prophylaxis is that it decreases not only the incidence of hypotension, but mostly the severity of hypotension if it occurs. And this is logical because fluid colloiding will preserve maternal cardiac output by preserving venous return. And this venous return usually is okay at the onset of spinal anesthesia, and cardiac output is even increased at onset of spinal anesthesia. But lately, when venous dilation starts to take place, venous return can become a little bit not enough, and therefore it can increase the severity of hypotension that was produced initially by the decrease in systemic vascular resistances.
Okay, and one more question about mothers with sepsis. Can you use noradrenaline in mother with sepsis? It's one of the participant question.
It's also a very interesting question. We don't have direct evidence in the setting of obstetric anesthesia and cesarean section. I mean, no direct study to answer this question, but we have a huge evidence in ICU setting that noradrenaline is much better than phenylephrine in septic patients. So for sure, we can say that particularly in septic patients, noradrenaline should be used instead of phenylephrine, although we don't have this evidence specifically in obstetric setting with caesarean section. But the evidence is so clear in ICU that clearly I think we can recommend it in this specific setting. Also in obstetrics.
I'm really okay with you about that. And so most of the questions are focused on practical use of noradrenaline in the everyday cesarean section. So your preconization, your recommendation is to change to noradrenaline and to have the option of noradrenaline for every patient in elective cesarean section and emergency cesarean section and high-risk parturients with the new neonatal data, and to have it available in every cesarean section.
Yes, this is my view, and for the reason I just detailed in my lecture, but still this is not the most consensual recommendation among experts worldwide, because still there is so much studies on phenylephrine that most experts still consider phenylephrine as being the first line vasopressor. But I think that this is going to change, because the more and more we have studies on noradrenaline, as I just showed you, the more and more it becomes clear that noradrenaline is at least as good as phenylephrine. Is very, very convenient to be used to use it by infusion, because it has a very quick onset and a very quick offset that prevent reactive hypertension when you stop the syringe. And as I show you, we have also evidence supporting that it promotes better oxygen delivery to the fetus via an increased uterine blood flow.
Very good. So I have a question for Victoria and Ban Lang. Can we use Remy fentanyl in obese parturients?
And Leon, you go first.
So what I'll probably say is that it is obviously not recommended, because I think with obesity, there's always a risk of having obstructive sleep apnea. I think that will be a risk for patients. So I think that so things that as much as possible, I think although it is possible, but I think the risk assessment should be done. And I think things that you definitely need to have very, very careful monitoring if you choose to go down that path. But things that I think what Victoria has alluded to is that things that I think having an early epidural would be the way to go. Things that placing the epidural early would actually be the way to go. And things that they also have a higher risk of having cesarean delivery, and therefore things that doing epidural extension would then be something which is much safer compared to using an opioid-based labor analgesia. Thank you. Yeah, Victoria, back to you.
Thank you.
Yes, I think Ban Lang, you're just reinforcing what I would have thought, that the first recommendation would be for an epidural, simply for avoiding all the systemic effects of the other options and the risk of desaturation, and as well as the benefits of having that epidural in from our perspective and from the patient's perspective in the case of a cesarean. I agree.
And I have a question to Victoria about combined spinal epidural. Can you develop for the participants the advantage of this technique in the obese patient, even in the technical insertion of the catheter, and also for prolongation of the duration of anesthesia?
Yeah, so I think a lot of people would choose a combined spinal epidural for a patient with obesity. And the case for the CSE just grows with each repeated cesarean section and potential surgical difficulty and prolongation of surgery. And it also grows if there's going to be a tubal ligation as well at the same time. So in that case, the duration of the surgery may exceed the duration of surgery, and may certainly exceed the anaesthetist's comfort during that extra period of time. And so with the combined spinal epidural, we get the rapid onset of a nice dense surgical block with the opportunity to extend that by dosing the epidural preemptively throughout the cesarean section.
And what about combine in labor analgesia?
Yeah, so certainly I believe there's a lot of institutional enthusiasm for this. Not at my institution. We still tend to do the straight epidural rather than the combined approach. And I understand different people will make a different case for that.
What I heard before is that the use of the combined technique make it sure that you have a good epidural catheter insertion, because you have spinal before insertion of the catheter, and easy view of the epidural space.
Yeah, so I imagine that if you've successfully located the epidural space and achieved CSF flow, then the chances are that you're going to be in the right place for placing that epidural. The one downside that I would see is that you may achieve that analgesia, but the epidural does remain untested until that analgesia wears off. And so that may require a little closer anesthetic attention for a longer period of time, but just to make sure of that.
Okay. And one of the participants asked to if you use echography to make it easier for the catheter insertion.
So use of ultrasound?
Ultrasound, yes.
Yes, there is increasing use within our institution of neuraxial ultrasound for placement of an epidural catheter. sometimes we can get an impression fairly quickly about whether the landmarks are palpable, and if the blind technique is going to be effective or possible. But I think more and more now, a pre-neuraxial marking up ultrasound is more and more likely to happen.
That's good. My question is about the adaptation to the weight of anticoagulant treatment. And antithrombotic low molecular weight heparin.
And
in one doses, 2 doses, adaptation to the weight.
And the placement of neuraxial catheters?
No, for prevention of the thrombotic risk of the patient.
Do you mean the increased anticoagulant dose because
Yes.
of their obesity, and then how that leads on to our
Yes.
response? Yes, I agree. So the obstetric physicians in our hospital will often do individualized dosing for obese parturients, especially if they have a cardiac valve or something where the risk of thrombosis is particularly significant. And so that may be guided by anti-10A activity. And so we end up with doses which are not covered in any ASRA guidelines or other guidelines that one may come across. However, we do have very good communication between the specialties, the obstetricians and the obstetric physicians who are prescribing these bigger doses, either because of the combination of obesity and some other prothrombotic risk factor. And in those situations, there's either bridging with unfractionated heparin, which is much easier for us to time, or depending on the background of the patient, a very good interval greater than 24 hours of cessation well ahead of labour or elective surgery.
Okay. And I have a last question for you, Victoria. Do you think that morbid obese patients should be referred to higher care level obstetric units because of the availability of tables and material? Or do you think that every obstetric unit must be able to receive and give excellent care for all obese patients due to the high risk in population?
Yeah, that's a really good question. I mean, obviously the rate of obesity, it doesn't choose where all the obese patients are going to be. So we need to look after patients where we provide services. However, if we think about the resources required for the care of an obese parturient, it's for a long period of time, and it involves not just anaesthetists and obstetricians, but certainly in the perioperative period or peripartum period, midwifery staff. Potentially difficulties monitoring the patient and the baby. Not just the intraoperative period, but the postpartum period and what type of high dependency observations may be required. And for a patient who is very obese, even when everything goes well, I think it's important to have those backups available, and they may not be available in all settings. And then, of course, there's what is painfully obvious in obstetric care is that often things don't go well. And then we have a lot of technical challenges and potentially without the available backup that may not be available in the smaller centres compared to the larger centres. So I think, I mean, it's very easy to talk about this from the perspective of someone who's at a larger centre, But I think what I've observed is that anaesthetists and obstetricians at the smaller centres have a very clear idea of what their capacity is and what they are willing to care for. And if there's any discomfort in our practice setting, if there's any discomfort on either side, then they will be transferred. And that's clearly difficult and sometimes very upsetting for patients. And that's kind of a whole different conversation about, are we providing adequate care in all regions?
Sure. Thank you very much for your answers. And please, Prof Ban Lang, we have some very interesting question too. The question of a participant is, on what stage of labor do you give PCA with Remi Fentanyl?
Thank you for the question.
When do you begin?
Yeah, so I think I've alluded to before. Things that I think for PCA Fentanyl, we actually can give it as long as the patient is in established labor. So I think we have also started early and also in advanced labor. I don't think that's a very big problem. I think the main thing take away is the fact that if the center decides to actually administer PCA Fentanyl, then I think one should actually make sure that there is careful monitoring. I think that's the most important portion rather than the stage of the labor. Thank you.
Perfect. And one other participant say, I'm highly interested in Remi Fentanyl for labor analgesia. Do you think we can combine this with epidural with partial success, especially during perineum laceration repair?
Okay, that's a very interesting question. Okay, so I think my personal take about this is that if the patient is actually already on epidural analgesia, so I think I don't think it's a good combination. I think first a top up of the epidural for the perineal repair actually would normally suffice, or the obstetrician can actually do local infiltration. So I don't think Remi Fentanyl would actually be appropriate in this particular case. Thank you.
Thank you. And my last question is for you and all the participants and speakers. I thank for this excellent session. And the last question is, how can we register for the World Congress of Anesthesia in Singapore? How can we be invited and all that? And this is a participant who has that. So you have perhaps to send a new slide and make it easy for people to come to the World Congress of Anesthesia. And now, thank you so much for this interesting session and for the very interactive participants' question. And we will let the place for the music and the last session of obstetric anesthesia in a short time. Thank you very much.
Thank you, Anne-Sophie, for moderating the session. I think I've put the website. Was that right? The one from MICE apps? Dr. Ban Lang, is that the correct website for the WCA? I hope that's the one. Then you can.
Yeah, I think so. I actually got it from the organizing chair who told me to put it in.
Yeah, put the I googled the WCA 2024 and I found the website. I think you can go to the register for the mailing list. So if the registration is open, then you can be informed later. So yeah, I'm very glad. It's hard to believe we have so many questions in such a short time. Thank you very much. Thank you, Victoria, Frederick, Ban Lang. Thank you very much. And yeah, just like Anne-Sophie said, I think she's very excited for the music after this. Thank you.
Thank you. Bye-bye.
Bye.